So yesterday we covered a fair set of bases. We didn't hit on everything we had originally planned, but we did address a number of key items. So in the morning, we talked about, we gave you an exposure to a model early on. This was a model which was actually hybrid in character, so it involved individuals circulating and then presenting for care in clinics. Those individuals circulating within the population interacted through networks. It actually had locations associated with them, although not GIS, full GIS context. And we saw how that model could help us understand evolution at the level of each individual in the population, but also at the level of population-wide statistics. So we had various graphs which gave outcomes as elicited from all these individuals in the model that broke down certain quantities of interest, like number of cumulative infections, at the level of particular subgroups, like high SES, low SES. We further saw that a model like that could be used to provide statistics which were longitudinal in character at the level of an individual. For example, count of number of times a given individual has gotten infected, and compared to their income in a scatter plot. And we could see patterns, high-level patterns, which were in no way programmed into the model. Rather, we said that they emerged from that model. They were emergent properties from the model. Those patterns resulted from not one parameter, not one specific parameter or one particular person's state, but rather the interaction of a whole set of different factors within the model. And it's reflective of what goes on in the world. When we have a traffic jam, it's not a reflection of any one car's engine state. It's an interaction between these different pieces. And a model lets us capture that fundamental fact, the fact that the behavior of the whole is often different from the behavior of the part. So we saw, for example, in that scatter plot, a gradient across incomes associated with number of times a person, basically health burden, number of times a person was infected. And that gradient was reflective of many things. It was reflective of the way people interact, the natural history of infection. It was reflective of in fact, the clinical care context, how many clinics were in place to treat people. It was reflective, in short, of many, many components of the model. Just like when you're looking at those numbers of people in the ER in a facility, it's reflective of many pieces of the system. It's not merely reflective of how many doctors are in the ED, although, that's important to it, or how many beds you have there. Surely those things affect it, but it's also reflective of downstream factors, how full the wards are, how many beds they have free. It's reflective even further downstream factors. How many long-term care facilities have beds, where they're located within the province compared to the patient's preferred or area of residence. It reflects to a certain degree the choice of patients between different options leaving, and the choice based on clinical considerations, transitional care unit versus placement in a long-term care facility for some rehab. But it also reflects things upstream. To a certain degree, in today's age, where we're discussing, perhaps providing paramedics a little bit more flexibility, what they can do in an ambulance, it reflects that division of labor. But it also is reflective of factors even more upstream. How much home care are these individuals getting? What's the quality of the home care? What's the strength of the primary care system in rural areas? These are tangled issues. They're tangled together, and yet they all end up affecting these things that we want to change, these things that the curves we want to bend, that rise in the waiting times in the ER. These are tangled things. They reflect many factors, and our models can capture that. In our model, we can have exactly that. And in fact, the model UN will show you has exactly those sort of components within it. And some of the other models we looked at yesterday, sought to capture that care context, those informal caregivers and aspects of individual health evolution that are relevant. So these are models that can simulate the kind of entanglement across the system and allow us to play out the state of the population over time so that we can see what emerges, just like we see things emerging at a high level, changes in wait times in the real world. So these models help us understand better, help us characterize and mimic the behavior of these complex systems, these systems that have these tangled components. But more than that, ladies and gentlemen, these models help us reason about what we can do to most effectively, the term that's sometimes used is manage those systems, to more effectively nudge them for the better. So we can ask counterfactual questions. We can ask, what if we put this in place? What if we had bullet rounding in place within our facility? What if we changed our techniques for trying to identify ALC patients? What if we put in place a change even to our facility layout to allow for placement of resources even closer by to cut down on the time for nurses to retrieve needed items? What if we were to consider having an ambulance system where paramedics could undertake certain types of interventions in the ambulance prior to getting to the ED? These are all what-if questions. We may not have the resources, the money to simulate to actually put in place in the real world. They may be prohibitively logistically challenging, or may take a long time to measure their effects. And we can use the model as kind of a thinking tool to think them through up front. Before we make that big investment, we want some confidence from the model that it's worthwhile. And we saw that the results of these interventions in the model, just like in the real world, were not necessarily linear in character. We could have an investment in some intervention that yields some results, but if we doubled the size of that investment, of that intervention, we wouldn't necessarily get double the change we did earlier. We might get something very different. We actually saw we could invest in intervention, and by one measure, it actually could be interpreted as kind of worsening things, as judged as through the imperfect lens of that measure, in terms of count of infections a person has experienced over their lifetime. On the other hand, if we invested enough, it could make a qualitative difference, and it's a totally different game. Totally different game. Those situations are known from the infectious disease context. After all, that's why we, as a nation, invested so heavily in vaccination, because with enough coverage, enough compliance, it can be a game changer in terms of the burden of childhood infectious diseases. But it's not often immediately recognized that often those tipping points can be found in many other areas. And models can help us reason about those tipping points. They can help us reason about how soon, how much, and in what way do we have to invest to secure the biggest bang for the buck. And to have confidence that we won't be fooling ourselves if we think about scaling it to a larger level. So these models are kind of these micro-worlds. Now, these models, though, are not perfect. They're no more perfect than our theories are, but they help us evolve our theories towards clarity and towards, as Francis Bacon put it, truth more quickly. It's not that they provide us the answer. It's not that they're some sort of silver bullet. Far from it. But they help us spot the inconsistencies between what we're thinking is how things work in the world and what actually is out there, by allowing us to see it just doesn't add up. You put those numbers in that we think are good into the model, and you see something totally different than what we see in the world. Something's got to give. Maybe it's the data quality side, maybe it's the model side. And I found big examples in my modeling work of both. cases where, we were referred to certain data, we put it into the model, and it just doesn't jive with it, and we're thinking something's wrong with our model. We go back to the stakeholders after a lot of work. We just can't get around this block. Help us figure out what's wrong with the model. And they look into the matter and they say, oh, actually, that's a data problem. That year they redefined this metric. Or, that for those set of years, the data quality is really spotty. And actually, we go away with confidence in the model and a newfound understanding that we have to be careful about which years of data we use. So, problems with models are not, and this is a key point, they're not a failure. They're not the crystal ball has failed us. They are rather an opportunity to learn something we didn't know about data quality, learn something we didn't know about how things must be working in the world, so that we can evolve towards a more true understanding of things in the world. So these models are not perfect any more than our thinking is perfect, but they can allow us to more quickly, robustly, and deeply advance our thinking about things out there. And they are best conducted in a team context. We heard a fair bit about this yesterday. Kurt, Jenny spoke about their experiences of working in teams. This is what UN is doing over at HQC. This is what we do with Alberta Health Services, with TB Control. These are various types of partnerships within a team where the modeler is just one person of many. Not particularly privileged, but they're the folks who are trying to draw together all this knowledge from others into this model, and the model is shared. And it's events like this one that provide a chance for people to learn a little bit about what these models do and how to interpret them, which are key in sort of spreading that knowledge. So you could have a modeler, someone who's perhaps really trained fairly deeply in modeling, like one of these fine TAs that are circulating, or not sometimes, and they can work together with your teams, and you could still run the model. You could look at the output. You could maybe even add in some outputs. You could run another intervention. You could go in and say, this model assumption seems questionable. We're going to have to get that part deepened of the model. Those are the sort of things we look for in a team context. The modeler is not the only one with the hands on the keyboard, so to speak. They're not the only one who's interacting with the model. They're not the only one who goes and looks at the internals of the model and sees the assumptions. That's a group activity. And we're going to hear more about that today as time allows. So these models are tools about learning more quickly, deeply, robustly about this tangled, complex world we live in, the tangled, complex healthcare system that we navigate in, so that we could try to nudge things for the better. And we saw a number of models yesterday that point us at some opportunities here. We further saw that there are several types of this sort of modeling. We talked about three types: system dynamics, agent-based modeling, and discrete event modeling. Oft practiced in isolation from one another. Traditionally, you either add a discrete event modeling project or a system dynamics project or an agent-based project, and you led that project potentially for years. And it was quite tribal. The people who practiced each of these rarely knew that much about the methods of the other one, and they'd be fairly defensive about it. And there are vestiges of this even unto today. Is that fair to say, Jeff? But increasingly, where we see the real value as being is weaving these techniques together. So maybe you have an area of your model where a cross-sectional depiction at an aggregate level confers a great deal of value. And you can quickly sort of put that out using a system dynamics approach. Maybe it's the low-risk components of your population. There may be certain areas of your model where you want to track individual level history, where you want to investigate interventions which are based on a person's history, which give differential treatment for frequent flyers or what have you who present for care. There may be cases where you want to really represent, resource dependencies as a fundamental component, and you can use discrete event modeling in a really powerful way. So you weave that together with these other modeling types with a shifting boundary as your learning evolves. What you do in more detail, what you do at an aggregate level, as your sense of kind of what needs more work evolves, and as you're learning with it. You're learning often shaping that decision. This is very powerful, very powerful. So we end up expanding those areas where we found great sensitivity to our assumptions with respect to the outcomes of interventions. We may find this particular area, the intervention, the difference between these two interventions is very sensitive to our assumptions there. So we'll simulate it in more detail. And common need and readily realizable. So those who are staying on the following 2 days after today will have a chance in this very room, 1 day from today. We'll be putting your hands on the keyboard and mouse, and you'll be building up a little hybrid model, which shows care-seeking behavior on the part of individuals based on health burden and a little bit of the interaction within a facility. So you'll actually be building it up. You'll see how that model is built. Not because I expect all of you to walk out of here like Athena born from Zeus's head, filled with knowledge about how to be a modeler, but rather so that there's no mysteries here. There's no or minimized mysteries, shall we say. There's minimal kind of magic that seems to be associated. You'll actually see how one of these models comes about. You'll get to have a peek inside it'll be unkind to say the sausage factory, but you'll get to see how these models come about. Hybrid models as well. Very recognizable and very powerful. And I'm proud that my students are some of the few of their generation in the world who learn hybrid modeling as an important part of their practice. Okay, so those were some reflections on yesterday. Trying to think. Oh yes, of course. Jeff's lecture also on e-health helped expose some understanding on the intersections of modeling on the one hand and e-health infrastructure on the other, based on his work in Australia. And Jeff will be with us to continue to shape our appreciation for many important aspects of modeling, and particularly in the healthcare context going forward these next few days. So the final thing we did yesterday was arguably one of the most important for the sake of this boot camp, and that was to identify a set of points of interest on the part of different parties. And we identified 5 projects here on the board, in which there seems to be some interest within the context of this group. And we're going to start this very morning with groups that are looking at these. Those groups could be as small as one student, one domain expert or domain stakeholder, but they could be much larger depending on your interests. So we're going to have one project that looks at this universal care unit, and that's with Ed. And the primary student stakeholder for this will be Kurt. Yes, he's outside with his ilk. So Ed and Kurt will be taking that forward. And for this, I'm going to suggest the room S388, which is just down at the end of the corridor and turn left. It's actually half of a larger room, and we'll be drawing a sort of divider across of it, a little bit like what we do in care facilities. Okay. The second one that we talked about was care provider resource plans. So this is more of a workflow issue, thinking about for the province as a whole, the number of providers to work with the project. And it turns out that one of our students, it's actually not my student, she's a student of a fellow faculty member, Sonia Vanderby, in engineering, but Anahita is her name, and she's going to be taking the lead from the student side. And remind me, who is it that came out with that from the participant side? Okay, and your name? Matum. Okay, and last name? Okay, so it's MB? Yeah, okay, great. So Anahita and Matum will be taking this on, and I'm going to suggest for them S386, which is also down to the left, but a few steps further than S388. They're sort of paired rooms on either side of a partition. So I'll ask Anahita to partner with you, and you can go down there and talk with her. And this is an area where Jeff has considerable experience as well. And so he'll probably be providing some particular guidance on that as well. Now, this issue of general practitioner and specialist visit linkages, sort of trying to link together and identify the GP visit associated with a given specialist visit. That issue is an interesting one. At first glance, it's an issue of analysis rather than synthesis in the sense that you're trying to identify these patterns from the data. But a model can actually lend significant insight into it in terms of providing a way of identifying potential patterns that you might use. And we have a student, Rahim Orji, who had mentioned some interest in that. Where's Rahim? Is he out there as well? Okay. Rahim? So this issue we spoke about yesterday with GPs and specialists, and you had noted the potential for machine learning use in that area. Are you willing to take that on as a project? Okay, so that may be something that Winchell could also comment on, or Dylan, in the sense of Dylan has a model where he's already got specialists and primary care represented that might be of use in terms of presenting a synthetic ground truth, presenting kind of from the model, this is how things might play out. And then you could try to assess different machine learning models that would identify this against that model. That would be one idea. So remind me the name of the person who suggested this? Okay, so it's V. And the last name? Okay, right. So VR? Yeah, okay. Great. And that one I think we'll put in with the leave of Aiden. I think we'll put it in. Well, let's see. Actually, Aiden will be in another one. So we'll put this in 342, S342, and the students can help guide you to that. So Rahim, if you could make sure you know where S342 is, it's over there, I think. That would be good. Okay. So this issue of bed strategy and patient cohorting and resourcing, I think that was from the back there. Is that right? And that was coming out of the Saskatoon Health Region. And I thought that that one could merit some more discussion. And kindly, Joachim and Jeff, I think, had offered to try to sort of elicit some more details on what's involved. We had two hypotheses for what you had in mind in terms of some of the specifics, and so a little bit of additional explication, discussion back and forth could go a long way in terms of focusing some of the efforts of the student. But either interpretation seems quite addressable in the sense that we could use modeling very fruitfully for either one. I'm going to see if I could ask Winchell, who I think is maybe finishing up the example. Could you get Winchell in here? Thanks. The elves are they like to mix with each other a lot too. So we'll see if we could get them in here. The Santa's workshop sometimes gets a little bit crowded for them, I guess. Okay, so this will be Winchell, and maybe you could mention your name. Leanne. Blayhut. Oh, okay. I know you. Okay. Okay. Good to put a face with a name. That's great. Yeah. I think emails and so on. That's great. Good to meet you, Leanne. So Winchell here will be. I'm asking him to partner with you on this one, and for this one, I think we'll use S371 is the room. Okay. So if you could meet up with Leanne and Jeff, and per interest, Joachim may be involved in hearing some of that. Okay. Okay. That will be great. Now, there's further work. So I know Narges is just outside there as well. Could you get Narges? Okay. So someone else from RQHR. Several parties we talked to last night on the nosocomial infection front, and Tyler, is she here? Yes, there you are. Great. And what I was thinking here is Narges Shurjati, who was with us during some of that discussion, and there's an additional student who's also involved, who's coming from the School of Public Health, but yourself and your last name again? Oh, great. Okay, so Liam, yeah. But your last initial, just so I see. Okay. C? Yeah. Okay, great. So I think this will be a natural team. And what I'm going to ask is one of the students here has been working in S341, and I'm going to ask that to be the room associated with that, I think. Okay, I'm just looking here. Okay, actually, I'm going to switch to, so that, because he already has a key for one of them. So I'm going to switch. This will be 341. Boom. That's the linkage with Raheem, and this will be S342. And that means, oops. Yes, that is that. Yep, 341 and 342. So this is for the nosocomial one. And they have a model that they've already been working on, which has nosocomial infection spread. And Mustafa is a student from the School of Public Health who's going to be here for some of this morning. And so he may be outside right now. Is Mustafa out there? Okay, great. So these are my suggestions. There's an additional one as well with Joachim and Dylan that it looks like we'll try to undertake as well. and you'll hear a little bit more about Joachim's context when he speaks, and you'll hear about something about the sort of area he's working on. But Dylan will be the primary student for that, and Dylan has access to. He's very familiar with this area, and we'll see if he can make use of an additional room. Okay, so that's great. Anyone else want to bring up something? Yeah. Oh, yeah. Far be it for me to blow against the wind. That's great. Yeah, absolutely. So, by all means. Just wondering where to put it. I think I'll make it 2.5. But okay, yeah.
We would like to know if new private MRI clinic where patients pay by their own expenses can help to relieve the wait time for you.
Okay. An MRI clinic? Myocardial infarction?
Just that MRI.
Okay. Oh, MRI. Oh, MRI. Okay. Yeah, I was thinking that's a pretty grim thing. If they go in with a heart attack and they have to pay. The rational decision making would be pretty difficult under those. MRI clinics. Okay. Wow. That's an interesting one. So MRI clinics with sort of I don't know, copay is not the right word, but it's sort of a private MRI.
Yeah.
Private MRI, right? I will see if we could identify an appropriate student who might be able to take that on. One of the things is Anahita, I know, has done quite a bit of background reading on the MRI context and the demand for MRI. But she's already working on this care provider workforce sort of planning type context. So we're going to have to figure out how she spends her time. But let me talk with Jeff and some of the students, and we'll see if we could have something done in that area, okay? So the idea would be to characterize, I guess, system-wide the MRIs in place and the demand, sort of the value stream associated with them, and then think about where a private MRI would fit into that and what its implications on system-wide demand, on servicing system-wide demand might be. Okay. I'll talk. We'll see if we might be able to do something in that area. I think it will involve someone with potentially some economic knowledge as well, and Winchell comes to mind. But anyway, we'll see what we can do with that. Okay, I'll talk about it during the break. I'm going to leave it for now unassigned to a room until we figure out who and so on. And your name? Xinhua. Okay. That's is it spelled with an H like a Taiwan or X is okay. Xinhua. Okay. Great. Okay. Wonderful. Anyone else with a project they'd like to advance? This is great. It's great. Projects will come. Projects will go. The open space model. That's my first experience with it. Hopefully we'll see some interesting flourishing. Great. Okay. Any questions? Any priorities? Any burning needs?
I don't have a burning need, but once we develop a model, how do we validate that?
Okay. Yeah, we're going to be talking about that some today. There's this gets into the whole issue of interfaces with data, and that's part of it, but it's not all of it. It turns out. So there's additional layers of what we call to call it validation is perhaps a bit presumptuous, because it's hard to ever completely validate a model. What you can do by Karl Popper's sort of perspective is you could try to work to falsify the model, to double check it, and to identify any problems with it. There's a falsifiability sort of perspective on it that you'll work with, and we'll see if we can hit on this issue in some of my discussion with models and data. Okay, so great question. Other questions? Yes.
If we're here just for today,
yeah.
Would be a good approach or best approach for using today's time and suggested?
Well, you mean as far as these groups, et cetera? Well, what I would suggest, and Jeff may have additional suggestions on this, what I would suggest is that if you're here only for today and you see a group that would be, where your knowledge could be potentially really shaping. It could be really important in shaping the evolution of that group, or informing it. Remember, these models are about theory and data. They're not just about data. And so a lot of what you might bring is an understanding of how the system works for this, how things fit together. If you see a project where that's the case, spending some time with that project would be much appreciated in the sense it could help get it further down the line in terms of putting together that model. You heard Kurt comment on it yesterday. When he put together one of those models we looked at, he spent a lot of time sort of sitting with people saying, okay, how does the flow within the hospital work? Jeff, I know, was particularly important here. How do the different wards deal with bed management? How do they, in what situations do they admit from the ED? How is the flow to community care options handled as far as ALC status? And that took quite an effort to kind of build up that structure. And we talk in models of these sorts as structure as determining behavior. What I mean by that is, it's not the case, and this actually gets back to Madhum's question. This is emphatically something to be emphasized. It's not the case that these models, if you plug in one set of data, plug in another set of data, you'll see, you can get any behavior you want, and therefore it's loosey-goosey. Actually, if you have a model and has a certain structure, meaning like what transitions go to what states or what stocks there are and flows between them, it turns out that the possible behaviors of that model are often pretty well circumscribed. You can only see certain types of behavior out of the model. For example, you might not be able to see oscillatory behavior out of a very simple model. You can only see certain types of behavior. Other types of models will shape the behavior. So the structure of the model, those state charts and how they're put together, the stocks and flows, or those flow maps within the discrete event modeling context, those really fundamentally shape, constrain the possible behaviors of the model. And if you put in different sets of data, you're going to see differences, almost certainly, but it won't be huge. It won't be often totally different, total solitudes in terms of what results. In fact, you'll often be seeing kind of different variants on the same theme of what comes out of the model. And this is why when we talk about validation of a model, using that term loosely, what we're talking about here is often, trying to spot situations where the model the results it produces are inconsistent with our empirical observations. And often that's much easier than you might think, because you can't get any fit to it. You can't produce any output from it. You can only produce certain circumscribed outputs. So the model will often very quickly tell you if it's misaligned with the empirical evidence, because try as you might, you're just not going to be able to get it to match the data you have available with this existing structure. And in that case, you often look into the data. Could there be an issue with the data? And you look into the model structure, and you have to think about modifying it. So structure of these models determines a lot about their possible behavior. And so it is with the world. It's not just in the model. These models mimic things in the world. And a lot of the time, I hate to tell you this, folks, but the structure of the systems we build, the structure of the healthcare system, the structure of your hospitals, the structure of how the flow processes work, those limit what we can do, what we can change effectively. They provide pretty tight constraints sometimes about what's achievable. And some of the most interesting uses of models of this sort at a very high level of policy have occurred, for example, in taking a model and using it to assess stated or planned, discussed targets for certain types of outcomes, and realizing that, sorry to say, but there ain't no way in hell you're going to be able to realize these change within the desired time frame. It's just impossible. Or, it's physically impossible to have that happen. It would imply an impossibility. And these models can then help bring the discussion back to the table. Okay, what is an achievable target? What is an achievable time frame for that target? What could we realistically do within the constraints we have? This is a very important point about these models. They're not loosey-goosey. You plug in any data, you get totally different things, and therefore, you can fool yourself really easily. No, they tell you a lot. They say, I can't do that, sorry. And you say, okay, well, must be we have to posit another structure. I view that as a positive, not a negative. I view them as keeping us honest. We can't get anything we want out of a given model and have it match anything, or else, it wouldn't tell us much about what's going on in the world. Any assumption about what's going on in the world, we can make match the data, and that's not the case. It's very constrained. We often have to be quite accurate in our depiction of things for it to kind of jibe with the evidence. So, what does this all come back to do with your question? What it all comes back to do is that eliciting model structure. Eliciting that structure of the model, how to depict the system, is absolutely central. And I would actually say here, and I exhibit a certain measure of discomfort saying this, but I think Jeff will back me up in an emphatic fashion, is that I would say the structure of the model is actually rather more important than the data. Jeff, do you agree?
In some audiences, I agree entirely. And this is one of them.
Yes, yeah. The
audiences, I don't know whether I have the bravery to say that.
Okay. Yeah, what I would say is you can learn with the right structure, but poor data, you can learn a lot more than you can with the right data and poor structure. Is that fair to say? That's what I mean by this. The model actually, you learn a lot more from having the right structure than you do from the data. I'm not going to say that all these projects can be undertaken with no data. No, that would be foolhardy in the most profound way. But what I would say is that getting the structure right is an absolutely fundamental step. Lack of data, we almost always have to deal with lack of data, and there's a lot of ways to deal with it, but still be kept honest by the model structure. So, if you only have today, that's all you got, I would say if there's a group where you feel your knowledge can be brought to the table and you're interested in seeing what these discussions are like, go to that group and have that discussion, and you may contribute a lot. And we'll make sure those who do leave have a chance to see some of the fruits of this model. Just, write to me and you can see what came of this and see subsequent discussions perhaps after the context of this boot camp. So that would be really valuable to go to that. I would say if any of you are interested in kind of seeing these projects play out, and maybe you don't have any one project where you think you could contribute a lot, but you're interested in kind of seeing it, I would say if you only have today, go by towards later in the day when things have been percolating a bit and see what's going on. Circulate. Go in. I was going to say, okay, this is unkind. Yeah, no, I have to be very careful with this analogy, but it's kind of like going and seeing different exhibits. I was going to say in a zoo, but it's more of a museum. There's no cages here, okay? Although they've talked about building one for me in Australia. So So in any case, you could go to different projects and kind of see what's going on. Oh, this looks interesting. Okay, there's a model kind of starting to take place. There's some opportunities to learn about the modeling process, even if you don't have particular data, knowledge you're bringing to bear or data you're bringing to bear on any one of these. Okay, so I would encourage you to do that. I think that's great, and I recognize that for some of the day, the modelers here may be working alone. The stakeholder wants to come back here and lecture. Great, no problem. And often what happens is it will take the modeler, 15 minutes or half an hour to go work on something that's been requested. And meanwhile, the stakeholder could come back and then go back there. So you may circulate. You may find just the modeler toiling away to build something that the stakeholders requested. And it'll be a quite fluid situation. But please go by and visit those things. That'll be a lot of fun. It's an analogy that's just not making its way out of my head for what this will be like, but it'll be an interesting little glimpse of different micro worlds that will be taking place. Jeff, any comments on that? Open space.
Open space. Again, people. The idea really is for people just to do what they think makes the most sense and is the most value with their time.
Right.
Instead of us imposing what we think is valuable, it's really in your hands. A smorgasbord of grazing opportunities.
Yeah, that's a nice way to put it. Intellectual grazing. Okay. Okay. Any questions to that? Questions? Okay. Great. So I think we should have those things go forward, and once we pin down Joachim's room with Dylan, I'll post that up there. I'll talk with Dylan about possible rooms. Okay? He's a room connoisseur from this area. Okay. Great. Okay. Excellent. So, okay. So it's about 9:00. We have a lot of material to cover today. So I've got to decide, do I do the health break right now or do I do it in an hour? How many people would like the health break right now? Okay, so we'll get started and we'll do it in about an hour's time. Terrific. So let me stop this. This is